So we're preparing for live streaming.
Okay.
So we're preparing for live. Okay, again, try. So I get I try. Mauricio Castaldelli-Maja, who is professor of psychiatry in Sao Paulo in Brazil. He's talking about tobacco smoking and mental health. I think we met before and we were joined in the publication committee of the World Psychiatric Association, and since then you have done quite impressive stuff and published with us. So I'm very grateful for your talk, and I think one of the big issues we already mentioned, if people would focus on smoking and smoking cessation, life would be much better for mental health. But we are quite keen to learn on that. So please go ahead then. Are you okay?
Just one moment. Okay, so thank you, Heiner, a lot for your invitation. You are doing a very beautiful work in Global Psychiatric Association. I'm really happy to be here, to be invited. I hope we can keep doing this annual conferences, and hope to do it in person sometime, that perhaps in the next year or so. And so I'm working on tobacco smoking for a decade, I think, right now. And we have, I think everybody knows that in most of the countries we have effective policy for tobacco control, and we have some very good cases. Brazil is one of these cases, United States, and a lot of other European countries I could name here. And these policies include a lot of interventions that we experience in our lives, like banning on public, banning of smoking in public places, first the closed places and then the open places. And so we today we have we had in the moment more than half of people smoking in many Western countries, and now we have I think about 18 or 17%. However, we still have some remaining special groups. Some people name them the forgotten subpopulations, in which is very difficult to prevent tobacco smoking and or to treat, or in which we have any specificity on the treatment. So why are they so important? I'm going to name them, examples of them, but why are they so important? Because they need special care in many cases. They have higher rates than the general population. They have some shared vulnerability for tobacco and the disease or the disorder itself. They are refractory to treatment, and there are some negative roles on treatment and prognosis. So who are them? Who are them? People living with mental health and addiction disorders. We have people with tuberculosis, living with tuberculosis, people living with HIV, the pregnant, sexual minorities, adolescents, people living with cancer, diabetes, cardiovascular diseases, respiratory diseases, and some others. But I think here we have, from the health perspective, we have the most important. especially important for us are, and I'm saying, I know that we don't have only psychiatrists here, so it's not only for psychiatrists, but for mental health professionals, people living with mental health and addictive disorders. And so we live this since 1964, a huge decrease in smoking prevalence. We say that on 1964, we had the first document reporting, big document reporting the bad effects of tobacco for health in the United States. However, it's interesting to see that at that point, we have a little bit more than half of people, of the adults, smoking in the United States, for example. And now we have around 18. And 53% is more or less the smoking prevalence among people living with mental disorder. So it's the scenario is a little bit, it's like we are stopped in the time since 1964 for people living with mental health and addiction regarding smoking, or obviously. If we look at from another perspective and get the smokers nowadays, we will find a very around 21 and 31% of smokers having any mental health disorder. So it's very difficult to not talk about smoking in the mental health sector. But it's usually what we do, what we currently do. So it's something that is like, is a little bit like alcohol, in terms that is like people say, oh, this is the elephant inside the room, because we are talking about the mental disorder, treating the mental disorder, and there is an elephant inside the room that we don't approach, we don't see. And this is alcohol, this is smoking in the mental health care practice. And sometimes we stay with the patient for 1 decade and we don't approach their dependence for smoking and also for alcohol. It's something quite similar in some sense. So how frequent it is? It's about, for schizophrenia is one of the most affected subgroups with around 70%, bipolar with around 60%, depression around 40%, and people living with other dependencies, we have very high rates, around 70%. I think that the highest prevalence of smoking is among people with opioid dependence. But here we can see this is a very well-known study from Morisano, in which Morisano and colleagues, they compare the cohort of people living with mental health and addiction disorders with the general population in the US and in Canada. And so there is a huge gap. I think that you know that. And why does it happen? And there are a lot of theories, really a lot, not only in the psychiatric field, but also in the psychology and neuroscience field. Here I'm just summarizing what I think it's the most interesting, but we are far from knowing all the determinants for this comorbidity. But so there is a lot of studies talking about shared vulnerability, especially neurobiological studies, but not only, also clinical studies. So people will have vulnerability for both mental health and tobacco dependence, mental health disorder and tobacco dependence. We also have a lot of research on social determinants. So how people who have will have more access to tobacco, more chance to experiment with tobacco, will have also more chance for having the mental disorders. The question of having less treatment access for both disorders, the role of the stressful environment, and also low socioeconomic status, which is associated with both tobacco dependence and mental disorders. Self-medication is also interesting and good, I think, to explain part of the comorbidity, because tobacco has some very desirable effects for people living with mental disorders. There are, especially when nicotine has the effect on alpha-7 receptor, we have an improvement in cognition. And this is something that could be desirable for the symptoms of the disorders and also for the side effects of psychiatric medications. And so this is also that there is a lot of studies approaching this explanation for the association. There are some people that are more affected, even more affected. So we have a Rome list in which we have very high prevalence of both smoking, tobacco dependence, and mental disorders. We have people with early smoking onset having a very high incidence of mental disorders also, and this is something that people are investigating a lot, and there is a lot of investigation on dual pathology. And in people who are the most severe cases of mental disorders who experience inpatient treatment for the mental disorders, also have more chance to start smoking and to smoke more. Unfortunately, the mental health care units are places where people learn to smoke more, and so smoking is minimized in this settings in most of the countries. This is something that is very interesting, because it's very difficult to find a place where in a mental health care unit we have smoking treated as an important mental disorder and as something that which we have to approach. It's very difficult to find. It's not impossible, but it's very difficult. One of the questions that our patients will ask themselves and also us is it worth stopping at my age? And the answer is yes. I say that because many of our patients are adults, middle-aged adults, or people close to elderly, and I think it's quite reasonable to think, is it worth stopping now or not? Especially yet till the 45, it's very, very, very beneficial. So you can see in this study carried out by JOAO, it's quite old right now, but very interesting. It's a cohort of physicians, and you can see in the red curve non-smokers, and in the blue curve the cigarette smokers. They were followed during their lives, and we have a dotted curve, which is the curve for people who stopped smoking. So they divided the graphs in 4 graphs. So in one of the graphs, they compared the people who stopped between 25 and 34, and you can see that the survival curve here is very similar to non-smokers. It's quite interesting to see that at some point it's still even a little better, but we can say that's similar. So stopping between 25 and 34 is really something beneficial. Between 35 and 44 is also something quite beneficial. We have around a curve that is around 90% here, so we can say that you revert 90% of the mortality. When we come to people with 45 and 54, it's a little bit more difficult. We have around 50% of decrease in mortality. But even between 55 and 64, which is people who smoked, I think, all the life, we can say that there is a very good diminution. We have a decrease in 35 and 40%. So it's the answer is always good. It's always good to stop. When we have an analysis of the attributed mortality of smoking, we can see that we have people with severe mental disorders have around 50% of attributed mortality to smoking compared to people with mild mental disorders. This is quite the same scenario comparing people with severe mental disorders and the general population, in which we have, I think, around 15%. So especially people with severe mental disorders have the problem. And these people die 25 years earlier than people without, the people with mild mental disorders. And tobacco is a really important factor for it. We have also combined risk factors like a higher cardiovascular and cancer mortality among people with severe mental disorder, low compliance with treatment, both for mental health treatment and clinical treatment. So these are also factors that put these people at a very increased risk for mortality during life. And when we come to our population, which are the main barriers when we try to implement tobacco cessation and addiction and mental health care units? So we have a lot of false perceptions regarding smoking, the perceptions that it's not possible to treat tobacco among people with severe mental disorders or with living with addiction. Some resistance to incorporate smoking cessation treatment in the mental health settings. Most of the countries, smoking cessation is implemented in the primary care. And so there are a lot of policies for this kind of implementation. So it became a little bit something that is not is not our job to treat tobacco. So, but the problem is that people in the primary care doesn't want, they feel, they don't feel comfortable to treat people with mental disorders for smoking. And they are afraid of some of the complications that I'm going to show here, but about the interaction in the medication for smoking and for the mental disorder, if the smoking can, the quit smoking can interfere in the mental health status of the patient. So it's something that we are going to talk. But one of the things that I want to say here is that it's really important to incorporate smoking cessation treatment in the mental health care setting for people living with mental health. We don't want, I'm not saying here that mental health care facilities should treat smoking for the general population, because it's really something we have around, as I just said, we have around 16% of daily smoking prevalence in most of as an average in the country. So it's a lot of people, and a lot of people that want to be treated. So it's something that is not. It will overload the mental health facility. There is also some resistance to cognitive behavioral therapy, which is the most used therapy for smoking cessation, and also some resistance to the use of medication for treating tobacco. There is some kind of preference on psychosocial treatments. And psychosocial treatments, we are going to see in the next slides, are also good, but medication increase a lot the chances of stopping. So it's really important to incorporate them. But one could say, how should we approach it? Is it the same approach of the general population? Is it different? Yes and no. We have above the line, we have some concepts that are both for people, the general population, and people even with mental disorders. You should have a detailed evaluation of previous and current smoking profile. You should assess the perceived benefits of quitting. So one of them is the one that we just talked about. Is it worth? Yes, it's worth. At any age, yes, at any age. Which are the main diseases that we prevent? Cancer, cardiovascular diseases, and respiratory diseases. Assess the motivation to quit. This is something that is just for all the persons that are thinking about quitting smoking. So we use a lot the Prochaska and Clemente model framework to assess the motivation. So this is something that is quite similar. However, specifically for our subpopulation, we have few studies. Our people were not included in most of the trials. I think this scenario is improving since the last decade. We have more studies. I personally believe that it's really important to look at the stabilization of the mental disorder to start treating smoking, because it's really difficult to, for example, evaluate motivation or assess the perceived benefits if someone is, for example, in the middle of psychotic circles, or in a very depressed with, for example, suicidal thoughts. So I really believe that it's important to look at, to search for stabilization before treating smoking. But we have to do it sometime. So this is something that when the person is better, we should approach and assess the smoking and approach, start to treat. One exception here is that people who are in the inpatient treatment, these people are, many times it's not allowed to smoke. In many countries, it's not allowed to smoke in inpatient facilities. So people are a kind of, they have to stop smoking. So it's really important to have medications and approach, psychological, psychosocial approach implemented in these inpatient units. Not only not allowing people to smoke, but also offering a treatment is a good opportunity, because despite people are not stabilized, they are in an inpatient treatment. They are monitored for all the symptoms. So it's good. It's good. It's the exception for this statement here. It's also important to ask and assess if people were using tobacco to improve the mental disorder and for improving any possible side effects of smoking. And this is difficult, but the person we are going to talk about withdrawal in the next slides, but you have to educate people here and say to them that this is something that is going to improve. Most of the trials show that people have an improvement in the mental disorder in the midterm, when some months after stopping smoking, and also in the long term, in 1 year, 2 years after stopping smoking. So stopping smoking make a good effect for the mental disorder in the mid and the long term. This is something that is quite evidence-based, and there is a lot of studies showing that. And it's also important, as I say, to integrate the treatment in the mental health facility for our patients. If it's not the case, we really advocate for people contacting each other. So people from primary care contacting people in the mental health facilities, getting the phone and calling and say, oh, we are going to start the tobacco treatment here. Should we do something? And also to make some evaluation during the treatment to see if the treatment are producing any bad effects for the mental disorder of the patient. We have pharmacotherapy and also psychotherapeutic interventions. They should be used together, always possible. We should use both interventions. The pharmacotherapy target more the physical, the concept of physical dependence, which includes the withdrawal, nicotine withdrawal. And the psychotherapeutic intervention target more the psychological and the behavioral and social aspects of the dependence. Here we have the main barrier for stopping smoking. All the studies show that the main reason for relapse when someone is trying to quit is nicotine withdrawal. It takes like from 1 month to 3 months, depending on the person. But most of the symptoms and the most difficult part of it is the first month. The first month is really something difficult. And we have physical symptoms that bradycardia, for example, that has sometimes people, it's not a really problematic symptom, but people can refer some kind of not feeling strong to do the thing. So sometimes bradycardia, it's really difficult to have a clinical significant effect, but it's good to know. However, increased appetite is something that is really difficult to deal. Women tend to have more than male, and this is a barrier, and it's because of that that it's really important to have a good treatment implemented, especially pharmacological. We are going to talk. Insomnia, craving, in the kind of the psychological, entering the psychological symptoms. Affective symptoms, so we have depressive symptoms, anxiety symptoms, irritability. People become very, very difficult to live with. And it's because of that that we really support also that we educate the relatives of these people, the person who live with a person who is trying to stop smoking, because they are going to feel also the effects of the treatment. And also difficult concentration. and concentrating is something that is it's really quite prevalent during the first month. During the second and the third month, we have increased appetite is something that also tend to keep appearing, and also depressive symptoms. It's important to say that the depressive symptoms can be very, very hard and severe, and you could have suicidal thoughts during this process. So it's because of that that's really, really important to have a good pharmacological treatment. Which are the evidence-based treatment? And here we have all the tested interventions. Not all of them have efficacy, proven efficacy, but part of them have. So we have the brief intervention, which is it's very useful. It's something that is used a lot in the primary care. So we have efficacy. We have the intensive intervention, which is different types of psychotherapy, especially supportive counseling. It's not really a classic psychotherapy, but is more psychotherapy targeting the smoking cessation. So we have a mix of motivational interviewing with some CBT concepts, and also some psychoeducation on the symptoms of withdrawal, on the main barriers to overcome the challenges. So it's really something. It's not a typical psychotherapy. We have also self-help materials which help a lot. The smoking cessation groups, which are a type of group psychotherapy, but targeting smoking cessation. We have exercise also. We have, but our exercise is something that increases the chance of people quitting smoking as an adjuvant therapy. It's not a therapy to be only implemented for smoking cessation, but increase a lot the chance of stopping. We also have a nicotine replacement treatment. We have 6 different types of nicotine replacement. The most concentrated types are the patches and also the gums. We have bupropion, varenicline, cytidine, clonidine, and nortriptyline as the oral medications that are evidence-based for smoking cessation. We have the first group. We have the most efficacy, the higher level of efficacy for medications are seen for nicotine replacement, bupropion, and varenicline. The other medications are second-line medications, so cytidine, clonidine, and nortriptyline. You should use these medications when you don't have access to these 3 options here. One of the questions that are really, really important is if we have neuropsychiatric adverse effects during the treatment, especially associated with medications or not. And this is the EAGLES study, is the largest randomized controlled trial conducted ever in the mental health field. It gathered, they included 8,000 people, 4,000 with psychiatric disorders, 4,000 without psychiatric disorders. And the main research question was not about efficacy, but about the neuropsychiatric adverse effects. And they compared 4 arms. One arm was varenicline, the other was bupropion, the other nicotine patch, and placebo. All the groups received supportive counseling during the treatment. And the study showed that there was not significant increase in neuropsychiatric effects attributed to any of the medications, so to varenicline, bupropion, nicotine patch, or even the placebo. So it's very safe to use these medications when treating smoking in your patient, both for people with and without mental disorders. It's something that about the efficacy. We have varenicline as the most efficacious medication, followed by bupropion and nicotine patch here, and followed by placebo. Placebo was not only placebo, was the psychotherapy, and we have around 13% of efficacy for psychotherapy alone. So it's something that the study confirmed a very well-known rate of success. If you combine bupropion and the patch, you have something very close to 38% here in varenicline. So it's something that we can do in the first treatment of the patient. If you associate nicotine patch and another type of nicotine replacement treatment like the gum or the nasal spray, you can also come here. If you combine bupropion and two types of nicotine replacement treatment, you can also be around here and even a higher efficacy rate. We should take care because tobacco itself can interfere in the levels of the psychiatric medications. The most important interactions are with some antipsychotics like olanzapine, clozapine, haloperidol, chlorpromazine, fluphenazine, and also with fluvoxamine, tricyclic antidepressants. And so what can happen is that when people stop smoking, you have an increase in the levels, in the blood levels of these medications, and possibly you will have side effects. This is something that's quite that happened a lot in the clinical practice, and so it's something to take good care. Another thing that is you should think about is the interaction with other medications, because our patients use a lot of medications sometimes. And the most problematic case is bupropion, but because bupropion has some effects on the cytochrome 2b6 and 2d6, and several medications are metabolized by this parts of the cytochrome. So bupropion is a very good medication for treating smoking, and you should not avoid this medication. You should only take care and see if the medications of the patient are metabolized by 2b6 or 2d6, and even if they are, there is no contraindication. You can use and monitorize how the level of the medication goes by asking about some kind of side effect of the medication that can happen. But you have to monitorize a bit more. Then the other two medications, the nicotine replacement treatment and varenicline, doesn't affect any medication, because varenicline is only metabolized by kidney, and NRT is just metabolized by 2A, just have effects on the 2A6 part of the cytochrome. So it's really easy to go with these medications. I think is that I just have a final slide here that I want to there's a conclusion to say about this topic, that stop smoking is good at any age. At middle age, decreased mortality a lot, so it's really something to be offered to our patients. This treatment is not usually offered in the mental health setting, so it's something that we should fight for it, we should implement in our clinical practice. If we're going to ask people living with mental health and addiction, you are going to be surprised how that a lot of them want to quit. So thinking that they don't want to quit is something that you should not think, you should ask, because the patient knows if he wants or not we in our mind. So it's something to be asked. People don't ask that, and you are going to be surprised with the results and the answers of these questions. Sometimes they are not ready to go, most of the times, but if they want, it's something to be reminded, for example, every consultation. Medications and supportive counseling are well tolerated, especially when the mental health condition is stable. So it's something that I really suggest you to do in your outpatient practice. Longer and more intensive treatment can be more effective. In the EGOs, I don't say that, but our rates of efficacy are a kind of 25% less. We have 25% less efficacy in the treatment. So a lot of people are studying and conducting randomized controlled trials, not with 3 months, but with 6 months of treatment for people with mental disorders, especially with severe mental disorders. And the last statement is that reduction can be considered as an intermediate step. We have a lot of people smoking 40, 60 cigarettes per day. And when you have such kind of case, we support that you should ask people to go to, we use this a lot, from 60 to 16. But how? If the person smokes 1 cigarette per hour, they are not going to start the nicotine withdrawal, because nicotine withdrawal start around more than an hour, 2 hours, or 2 to 4 hours after the last cigarette. So if the person smokes 1 cigarette per hour, we will not have nicotine withdrawal. And it's interesting to see that coming from 60 to 16 is not so difficult as coming from 16 to 0. And so in this part of the treatment, we support that just psychoeducation and this kind of guidance would be very effective. We should not use medications in this phase of the treatment, but just start to work with the patient and explain these concepts to them. So I want to say thank you. Here is my email. I want, if you have any doubt after the Congress, if you want to write me, please just write, and I will be very happy to answer.
Okay, thanks a lot. I think that's an amazing talk, and I think we have to think about what we do with these things. The one thing, maybe if people are a bit shy, I would ask, why would people then smoke 60 cigarettes or up to 80 cigarettes if they don't have any symptoms? And the second question is, what would be, we have now this vaping, I think, and this is one of the big problems, what is the vaping doing in these circumstances?
Yeah, they have the level, the dependence is not only conditioned by withdrawal symptoms, but also by many other determinants. And we should, there is 2 components of tobacco dependence. One is the physical dependence, but as I showed, we have also the psychological, the behavioral, and also the social component of dependence. And the cigarette is many times it is really the friend of all the day long. And this is something that is very, people learn to smoke a lot in the mental health settings. The medications also, we can, it's something that can combat, can help people to combat the side effects of the medication. So they learn that, they are kind of learn that if they smoke, they will have less side effects. If they smoke, they will have improvement in some, for example, as I said, in cognition, some improvements that we really have. We have improvements in attention. We have some improvements in memory. This is not, especially in the acute phase of the use. So these are my, I think, the reasons for people smoking a lot. And the second question or commentary is really something. It's really something that we are living right now. And vape. There are bad and good news about vape. There are a lot of people that support, advocate for a kind of movement from traditional cigarette smoking to a kind of a harm reduction of using nicotine e-cigarettes or this kind of, any kind of electronic device for nicotine. There is not too many data supporting this, but is a theoretical statement that is advocated by these people. I think we should wait a bit more. So perhaps vaping nicotine could be better than the traditional cigarette in the middle and the long term. Okay, it could be. But in the other side, we have a lot of people, adolescents, is starting to use vaping nicotine, which is really something very dangerous. If we compare people in the 11th grade in the United States, we are going to see that there is much more people, adolescents, is using vaping nicotine than using traditional cigarette smoking. So it's a kind of a new epidemic that is coming, and we already know that vaping nicotine, we have cancer with this vaping nicotine. It is less cancer than with traditional cigarette. I think that the answer is yes, but we had a lot of advance in the last decades that we are now losing this advance. So it's something that's really sad, and I think that you should, in my opinion, you should not use electronic cigarettes to quit smoking. It's not something that I really will. I don't give and prescribe it for my patients, because as I show it to you, we already have the treatment. There is a lot of options. There is varenicline, bupropion, supportive counseling. In most of the countries, this a good example is Brazil. We have a free treatment for people, so we don't need this intermediate step. We already have the correct treatment and evidence-based treatment for smoking. But I must admit that people are using more and more electronic cigarettes, and this is a reality. So we should study and do research to see if it's something that will really be included as a harm reduction or not.
Okay, Seshni, you wanted to ask something.
Yes, thank you, thank you, Reina, and thank you, Dr. JOAO. That was brilliant, very interesting and comprehensive presentation. And I'm so glad that Reina picked up on the vaping, because that was one thing that I wanted to talk about, or ask you questions about. But I think the second thing, I'd rather go to the second question I had, because you have covered a lot of it. The second thing was about, and I'm glad that you mentioned it in your talk, about the medication, about clozapine and certain antipsychotics that interact with smoking. And I think that is something we see a lot in our inpatients and obviously outpatients as well. So I think my question there is something which is sort of tricky. I always find difficult, because we have obviously patients that we need to treat with antipsychotics. Most of them treatment resistant. They need to be on the medication, and at the same time, they're obviously their vices of smoking, and that's sort of their habits that they've had long standing. And I think the second thing is about comorbid substance misuse. So we see a lot here in the UK. We do see an increased amount of people in this cohort of patients that do use illicit substance, and specifically cannabis. So I think then obviously there's an additional addiction and comorbidities. And sorry, the third thing I did want to say was about, so I think there's another question as well coming up, but yeah, so it's quite difficult to manage these patients. So I don't know what's your suggestion, and maybe answer that, and then I can ask you the next question. Sorry.
Okay, just repeat the first question, because I had problems here to hear the first.
Oh, yeah, no, it was just about the clozapine and antipsychotics, and dealing with this cohort of patients, and how do we manage them, effectively, because in our inpatients, we do see a lot of patients that come, we have to start smoking cessation. And then there's obviously the difficulty, and I know you spoke about counseling, and that, I mean, we're fortunate in the UK, Dr. JOAO, that we have free NHS treatment as well. Like Brazil, the treatment is free for NHS, in the NHS for smoking cessation. So we do have this available for our patients. So yeah.
Okay. I think that at least how do we do here? And I'm not. It's just how do we do for clozapine, especially because clozapine is the most dangerous medication in terms of the side effects. I love clozapine, but we should monitorize. So what we do is that we take these patients of taking clozapine as they were starting the treatment with clozapine. We prescribe and ask for them to make the tests, the blood tests, the hemogram for the red cells counts. We take more care of them during the stopping smoking. It's really interesting, this, because it's something that I have to put in the slide, because at least in Brazil we had problems with one patient in which the clozapine started to make more effect, and he started to have the most undesirable side effects that are in the blood. The second question is that cannabis is something that it's becoming very, very challenging, because we don't have a treatment for cannabis, evidence-based in terms of pharmacotherapy. But what we are using is, I have to admit that we are using cannabidiol for treating both when we have this comorbidity. So, but really, I'm saying that, but please, it's just something off-label that you should evaluate in your practice. But we are doing it more and more here, because we have good effects for cannabis dependence. So it's something that we start to use bupropion together with cannabidiol, and so it's something that we use here. And about the difficulties, we should include tobacco dependence in a kind of really disease model, in terms of we can try to treat tobacco not only one time. We should treat any times we need to this patient to stop smoking. It's really common that people treat tobacco smoking one time, and then we don't have success, and then people give up on treating these people again. And most of the people will stop smoking in the second, in the third attempt. So it's something that, how do you do here in Brazil and in your clinic? Because we have a lot of patients there. We don't give up. It's something that we don't give up. And people keep coming because our patients are chronic. We see these patients for years.